Hello, good afternoon. I'm Dr. Spicher, here for another update about the coronavirus. This is an ongoing story, and probably I'll be back again to talk about it some more in the future because it keeps changing. So today I decided that maybe an appropriate title is now Learning to Live with It, because it seems like it's not going away. So we're going to talk a little bit about some updates, what new things we've learned about the coronavirus. We'll update our local situation in terms of COVID, and we'll talk a little bit about how we can learn to live with it, try to pick up some semblance of getting back to normalcy. Remember, as a matter of refresher, what we're talking about is a virus, a member of a family of viruses that have been around a long time. Only a few of them affect people, most of them affect animals. They're thought to represent maybe about 30% of the common cold. The new one is a virus called SARS-CoV-2, which is a coronavirus that came to us from an animal. So previously this was a virus that lived happily in bats, and somehow it found its way into some people in China around the end of last year, and the rest is history, as they say. This is what the bat looked like, where it came from. This is a Chinese horseshoe bat. Pretty handsome guy, huh? What's more interesting to me, at least, is that it didn't go directly from the bat to the person. We think it went by way of this guy. This is a pangolin, which is prized by people in China for its medicinal purposes. They use the scales in Chinese traditional medicines. And so the thought is that perhaps the virus went from bat to pangolin to person. So there you have it. Remember, SARS-CoV-2 is the name of the virus. The illness that it causes is what we call COVID, COVID-19, and so that's the term that most people use. But the virus itself is actually called SARS-CoV-2. The illness tends to make people sick when it does make people sick about, on average, 5 days after they come in contact with the virus. It can be up to 2 weeks, but most people start having symptoms around 4 to 5 days. Can cause a wide variety of symptoms, everything from few to no symptoms. Most often we see this in younger people, to very severe symptoms, as we know about in our senior population. It is a respiratory virus, and so it's generally transmitted through the air on droplets. For a while, there was quite a bit of talk about whether this was an airborne versus a droplet mode of transmission. That means that it floated in the air as a viral particle versus hitching a ride on droplets of moisture and saliva. And that makes a big difference in terms of how infectious it is. So some viruses, like measles, are what we call airborne. So they stay aloft in the air, floating around for hours in an area. Viruses that are droplet, they tend to fall to the ground and they don't stay around very long. So more and more evidence now, I think, is pointing to the fact that this is mostly a droplet type of transmission rather than airborne, and that makes it less infectious, and that makes it easier to control. So in general, you've heard this before, keeping distance helps, because those little droplets fall down to the ground before they can travel more than about 6 or more feet. Surfaces probably aren't as important as we thought at first. Certainly we don't need to worry about disinfecting our groceries and things like that, like we did at the beginning of the pandemic. Really, in the end, it turns out that this is mostly something we catch from being near other people and inhaling viral particles that come from those people. Occasionally, it can also be picked up by touching objects and then touching our eyes or our nose and transferring the viruses that way. In terms of the symptoms, again, a little bit of review here. The more severe symptoms tend to be respiratory ones, and those are the people that end up often getting the sickest and ending up in the hospital. Milder cases can be just some GI symptoms, maybe some taste abnormalities, but fever, shortness of breath, and chest pain are the more severe symptoms to be concerned about. A wide range in terms of severity, all the way from no symptoms at all to very fatal symptoms and severe illness. We find that if you have chronic medical conditions, if you're a male, if you're older, those are all things that tend to make symptoms worse if you're infected. Recently, there's been some thought about perhaps one's genetic predisposition can also play a role. And also, there's some thought about whether even the dose of the virus that you get. So, if you get if you don't have a mask on and somebody with the virus sneezes in your face and you get a lot of a virus, you're more likely to be sicker. If you're wearing a mask and somebody sneezes in your face, you're not going to inhale as many viral particles, and you may not get as sick. So there is a dose effect of the virus as well in terms of how sick people end up becoming. What has been more recently appreciated, I think, and is somewhat unique to this virus compared to even the flu or the cold viruses, is how much of the spread happens as a result of people who aren't sick. We call these asymptomatic people. They have no symptoms, they feel fine, but yet they have the virus and they shed the virus and they can spread it to other people. And some of these people are people who are just about to get sick, and we call those pre-symptomatic. So a few days before they start to get sick, they're shedding viruses. But there's also a lot of them that never do get sick. Particularly, this is probably true in younger people. So there's people who can be shedding the virus, feel perfectly fine, and that's what makes it really difficult to control and to trace. Recent information suggests that asymptomatic people can be just as infectious and have viral spreading and viral levels that are as high as people who are sick. Something else that we're just starting to appreciate is the long-term effects of people who do get sick with it. It's been one term that has been applied to this is called the long hauler syndrome. So these are people who get COVID and they never fully recover. They have long-term effects afterwards. They don't fully get back to normal. In general, most people after a week from a mild case, or maybe up to a month after a pretty severe case, most people by that point are feeling pretty well. But what we find is that there's a percentage, and we don't know for sure exactly, but it's not necessarily a small number, who continue to have maybe lung symptoms, and when we look at their lungs by CAT scan, we see scar tissue. So these are probably things that are going to be permanent. We see inflammation of the heart, and again, we don't know what the long-term effects of that are. And one thing that a lot of people who have this condition report is they just don't ever get their energy back. They feel foggy, sort of like a chronic fatigue kind of syndrome. So there's a lot of this that is just now being reported, and we'll learn more about it as time goes on. Again, regarding seniors, their symptoms may be mild. Like a lot of other symptoms that seniors have, it may just be a little bit of confusion or a little bit of weakness. Though we're always looking for fever, it may not always be there. And we also need to think about COVID when someone starts to have some GI symptoms, even different than respiratory symptoms. So it can be tricky to find. In children, recent studies have shown that younger children may not be as likely to transmit it. Studies out of South Korea and Finland and school-age children found that those in elementary school tended not to, even though they were sick, they tended and were infected, tended not to transmit it as much as those children above 10. Beyond 10, they tended to transmit it just as much as adults did. We're going to find that out in this country because, you know, some school districts are opening up and some aren't, and we'll see how it goes. So it's an experiment ongoing amongst us right now. Another pretty severe complication for children is something called multi-system inflammatory syndrome in children. And it seems that this is just an overexcitation, if you will, or too much inflammation, so that one's immune system gets turned on by the coronavirus, and then it just doesn't shut down after the infection goes away. And that goes on to then cause tissue damage, and that can be affecting the GI system, it can be affecting the heart, the blood vessels. Some children have died from this. It's pretty rare, so it's not a common thing. And fortunately, what we've seen is that since the spring, the number of cases is going down. So hopefully this is not going to be something that will be an ongoing problem for children. In terms of testing, this is an area that is a little bit complicated because the illness is so different in terms of how it presents. It can be hard to tell really who's infected, who's not, who we need to be concerned about. So remember, there are three basic types of tests. There's the PCR testing that tests for particles of the genetic material of the virus, not the virus itself, but just the genes of the virus. So that's the most sensitive. It can find little particles of the gene even when there aren't any live viruses present. The antigen test is really testing for the presence of the virus itself, the viral proteins, and that isn't as sensitive, so you don't find as much. It takes a higher level of virus for this to be a positive test. But in some ways that's helpful because the people who have a positive antigen test are probably the ones that are most infectious. So those are the ones we're really most concerned about. The advantage of the antigen testing is it can be point of care. You can get a result quickly as opposed to waiting days for results to come back as we do with the PCR testing. And then the antibody testing really is a blood test that tells us after the fact, have we been infected? Did our body make antibodies to the virus? So it's helpful for research purposes. It's helpful for determining how much virus is in the community. It can be helpful for determining who can donate plasma for the antibodies that they have to help other people who are sick with it. It's not the best test. It is subject to a lot of false positives because other coronaviruses can sometimes interfere with this test. So I don't order this very often, and I don't recommend people have it done because it can be hard to know how to interpret it. Does the presence of antibodies really mean that you're not going to get COVID again in the future? We don't know that yet. So if we look at sort of what happens in our bodies when we get infected with the virus, initially Initially, after about a week after infection is about the time when you'd expect your viral levels to be the highest, and you would be most likely to test positive, either with an antigen or a PCR test. And then maybe about a month later, we would expect the antibody levels to be the highest. So depending on when you test relative to when you were exposed to the virus, it could determine whether your test is positive or negative, and depending on which test you do. So it's important to keep this in mind when we're doing testing and knowing how to interpret the results of the tests. So we're all very familiar with the PCR testing now. Does that face look familiar to anybody? So this is really the best. This is kind of the gold standard test, believe it or not. This is about as good as it gets in terms of being able to detect the presence of the virus. In some ways, it can detect too much because it detects the presence of the genetic material. So even people who are fully recovered can still end up with positive tests because there's still some genetic material from the viruses, even if they're not sick and they're not actually infectious. So that's the part that we're still trying to sort out. But it is very sensitive, so if this test is negative, as long as it was collected appropriately, that person should not be infectious. In terms of the antigen testing, this is something that we're going to become more familiar with because all the facilities, ECFs across the country receive little kits, little machines to do antigen testing. This is a point of care test, so someone can come in, have a swab done, stick the sample in the machine, and within 15 minutes have the result. This is detecting the presence of the viral proteins, the virus itself, so it's not as sensitive. It won't find positives as often as a PCR test will, but it probably correlates better with whether or not you're infectious. This is what the machine looks like. This is, I think, actually one of the type that we actually are receiving. This is the kind of testing that the White House does all the time to keep the virus away from the president. This is the kind of testing that the sports teams do every day to keep their bubbles intact in the NBA and the NFL. This is the kind of testing that colleges are doing. And I suspect that in time, this is kind of what we'll be doing on a regular basis to try to keep our facilities safe. CMS has recently released guidelines for this testing for facilities and how often we test the staff at facilities. And this testing frequency really is based on how much virus is in the facility and how much virus is in the community. So right now, we're testing monthly. So that's why we're getting these monthly tests, because we don't have COVID at our facility, so that's low. And at this point, the county positivity rate is right at or just under 5%, and so at this point we can still test monthly. If the county positivity rate goes up, then we're going to have to start testing more frequently. So that's where the testing guidelines are coming from. Another way to kind of monitor what's happening with the virus in the community, and when I say community, I mean cities and counties, is to monitor it in the sewage system. Colleges and universities are starting to use this now to monitor for the presence of the virus on their college campuses. There was recently a situation where it was college found some COVID in their sewage system, and they could trace it back to a particular dorm, and then they could actually test everybody in that dorm, and in that way keep the virus under control. The federal government is actually setting up a national wastewater surveillance system to collect this data. So this, I think, will be a helpful way going forward for us to monitor how well we're controlling the virus. In terms of treatment, we're getting better. So there's good news. People are surviving more likely to survive if they end up hospitalized or end up in an ICU with COVID. We have an antiviral drug that has been approved, remdesivir. It kind of slows down and shortens the course of the disease. It's kind of like Tamiflu for flu. So it's not a cure, but it makes it less severe and shortens the course of time. The thing that has made the biggest difference has been dexamethasone, a steroid anti-inflammatory medicine. This has improved survival rates in people who are sick in the hospital on ventilators. As I mentioned earlier, another way of treating this is to take plasma from people who have recovered from the virus using their antibodies and infusing those antibodies into people who have the virus, and that seems to be helpful as well. There are some other treatments that are in the works, actually manufacturing antibodies to the virus. That is something that is not yet approved, but does show promise. The way we're going to get out of this ultimately probably has to do with prevention rather than treatment. And so we'll talk a little bit about where we stand with vaccination. There's over 90 vaccines that are around the world that are currently being studied. 42 of them are already in human trials. 9 of them are in the last phase, the phase 3 of human trials, where they're actually giving the vaccine to people and giving placebo to the other half of that group and seeing which people get the virus and how well they tolerate the vaccine. So 9 different vaccines are at that level, and that's the final phase before a vaccine is released. How long that will take is a matter of debate. My guess is it's going to be year-end at the earliest. There are 3 different vaccines that have been sort of the front runners and have received a lot of support from the government. Those would be the vaccines from Moderna, Pfizer, and AstraZeneca. There are a couple different ways that vaccines have been made. One is to take a little piece of the virus genetic material, the DNA or RNA, and just inject that into a person, and then that person's cells actually make the viral protein, and then their immune system develops antibodies to that protein. So you don't actually get a live virus, you don't actually get a virus at all, you just get a little bit of the genetic material from the virus. Another way is giving you a cold virus that has a little bit of the coronavirus in it. That's the AstraZeneca vaccine. Some vaccines are made by taking part of the virus, breaking up the virus and just giving you a little piece of it, a little bit of viral protein. And some vaccines are made by taking a whole virus and just killing it. And that's what we have as a flu. That's typical to what our flu shots are. Flu shots are basically dead viruses. And so our body recognizes these as foreign material, makes antibodies, and improves our immune response. So there's a lot of work being done, and I think a lot of hope in this regard in terms of vaccines. If we look at the numbers for our country, you can see we had a spike early in the spring, and then things sort of calmed down, the numbers came down after everything was closed down, and then we opened up and we started getting more testing availability, and then we saw a spike around August, and things have started to decline since then. And now maybe they're inching up a little bit more, and that may have to do with school opening, may have to do with the Labor Day holiday. So it's certainly not all going away at this point. The death rate, fortunately, is down. It's not certainly 0 yet. We're still just under 1,000 deaths per day in our country. But the trend does seem to be going down slowly. If we look at where the states where the coronavirus is currently, it tends to be the South, most predominantly. And if we look at, some will say, well, that's because they're doing more testing. It's not necessarily so. If you look at where the states that are doing the most testing, the states that are in dark blue are doing the most testing, the states in gray are doing the least. So if you look back where the virus is and where the testing is, it's not all the same. So it's more than just the testing. There is actually a lot more virus in some of those states right now. Fortunately, if we look at the fatality rate relative to the number of cases, that number is going down and it's stabilizing. So at this point, we're looking at about maybe 3%. And that's of the cases that we know of. So the true fatality rate for this virus is certainly less than 3%. But it is encouraging that it is slowly decreasing. If we look at what's happening in Pennsylvania, we had a pretty big spike early on, and despite actually doing more testing in Pennsylvania, our numbers are lower than they were in the spring. They're just kind of stable, I would say. If we look, interestingly enough, if we look at where the virus is in the state right now, anybody have a guess at what's in the middle of the state? Penn State, there you go. So that's what's happening this past week with the rate of coronaviruses in Pennsylvania. If we look at, I just thought this was interesting, looking at the experience of different states. If we look at the rate of infection early on you see Pennsylvania's rate was pretty high. That's the green line. So in the spring, more cases in Pennsylvania than Florida. Florida was kind of spared early on. And then later in the summer, Florida opened up and they really had a pretty high spike. And Pennsylvania stayed fairly flat relative to Florida. So I think it shows the difference in an approach to how a community handles the virus. So if we look at Lancaster County, I think that here certainly initially the story was all about nursing homes and the severe toll that the virus caused on the nursing homes early on. That's not happening as much now. In fact, the numbers are down. There's still occasional outbreaks at facilities, but for the most part, the facilities have been doing well recently. As of the 20th, we had 7,500 people test positive so far in Lancaster and 424 deaths. If we look at the cases in Lancaster County, they're just kind of staying there. Maybe a slow downtrend, but for the most part, it's not a very steep downtrend. It's kind of just flattening out. A lot of up and down, but it has gradually decreased a little bit from maybe where it was a month ago. So it's kind of static, I would say. Again, long-term care has been a significant problem with this virus, and that's why we're talking about this. Still accounting for up to 40% of the mortality across the country, and probably almost 3/4 of the mortality locally. Definitely improving recently. The mortality and the outbreaks in extended care facilities are significantly down this summer relative to the spring. Again, remember the reasons why it's such a problem in facilities. It's where we have lots of high-risk people living close together, and they're being taken care of by generally younger, healthier people who may not be aware that they're sick. And so early on, when there, I think, wasn't as much attention paid to PPE and masking, I think it got into our communities and wreaked havoc. I think we're doing a much better job now. If you look at the COVID-19 cases in long-term care facilities in Pennsylvania, you can see how high the numbers were early on relative to now. It's kind of really flattened out, and these numbers are down despite universal testing. So think about all the testing that's happening at every facility, in the state, and the fact that the cases really did not spike up when they started doing universal testing. So I find that encouraging. And if you look at the deaths, which are the best measure of what's happening with the virus, is certainly not a function of testing when we're counting people, mortality rates, they're down, and they have stayed down. And so that, I think, kudos to extended care, long-term care communities for managing this. Again, in Lancaster County, the majority, I would say, of the facilities in Lancaster County did experience fatalities related to COVID-19. The last count I was able to find was at 309, and 374 healthcare workers from long-term care tested positive. I'm not aware of any fatalities of any long-term care workers, however. Our own experience here at St. Anne's has been wonderful. We have not had COVID amongst our residents, and that is certainly something to be proud of, and we're one of few facilities in the county who can say that. So we continue with our testing. We continue to be on guard and try to keep the virus out. In terms of how we do that, I think probably, my own opinion, I think the masks make the biggest difference. Certainly hand washing, social distancing where we can. Obviously we can't always do that with our residents. With universal testing, we have a better idea of whether it is present or not and who needs to be quarantined. Again, as the numbers in our community go down, the risk to long-term care goes down. In general, anything we can do outdoors is safer. So outdoors are always safer than indoors. Universal testing, this is something that has now been mandated. So any time that we have a positive resident or staff member, we need to test everybody all over again like we did at the beginning. And we need to keep testing until we don't find any more positives. So in that way, we can hopefully stay ahead of this and keep it controlled and out. It really is the only way we're going to find people who are asymptomatic carriers of the virus, because by nature of being asymptomatic, they may not have fevers or, of course, not any symptoms, and so just screening by questionnaires or taking temperatures is not going to find people who are potential carriers. We have received the point-of-care antigen testing machines, and at some point we're going to be starting to use those. At this point, we're still using the companies that come in and do the testing of the staff. So how do we continue to keep our residents safe? I would say that probably the most important thing is make sure we're always wearing masks, washing hands frequently, making sure that if you're sick or even think you're a little bit sick, you really should just stay home and be sure. We're doing screening and, of course, universal testing. Again, masks, I think, are most important. It's probably the best way to prevent spread of the disease, but I think it also helps protect the person wearing the mask. And this isn't something that was appreciated early on. In fact, early on, there wasn't even a lot of emphasis placed on wearing masks, and I think more and more the evidence is coming in that masks really help the person who's wearing the mask, and they also help decrease the spread. So if someone wearing a mask is exposed, they may not get as many viral particles, less likely to get sick, and if they do get sick, may be more likely to have a mild case. There have been some good studies in healthcare settings, particularly large hospital settings, where they looked at sort of the spread of COVID before and after universal masking of the staff, and there have been some pretty significant differences seen. I think I might have mentioned this last time, the incidents of the Missouri hair salon, which I think was just really pretty dramatic. You know, 2 hairstylists who were sick, they were symptomatic, and they kept on cutting hair. But they had their masks on, and all of their clients had their masks on, and at the end of the day, 139 people had their hair cut, and they didn't get sick. And they were tested, and there was no transmission of the virus. So, you know, I think a pretty significant example of how effective masking can be if both parties are wearing masks. And I think this is, you know, this is something that will allow us to get closer back to normal in terms of things that we do in society, things we do here at St. Anne's if we adhere to the masking. Of course, it's important that we wear it correctly. It's not a neck warmer. It needs to cover your nose and mouth. At St. Anne's, this is something that has changed since I spoke to you last. We are starting to relax regulations about visitation. We're starting to reopen, so we've started outdoor visits, and we'll continue to do that depending on, you know, what the positivity rate is locally. I think we'll be able to do more of this. We'll be able to relax more if we are able to start doing more testing. So that's something we're looking at. Maybe, you know, even looking at maybe testing visitors. And CMS has come out and recommended that we even start looking at in-facility visitation. So that's something that we're looking at and developing policies for as well. You know, in the end, it's finding the right balance between resident safety and resident well-being, family satisfaction. You know, certainly our residents have suffered emotionally and even physically with the isolation that has been imposed by all of our well-intentioned efforts to keep the virus out. But it does come at a cost, and so we have to continue to look at this and find the balance between resident and family well-being and safety and keeping the virus out. So there's going to be fits and starts, I'm sure. So we may go in one direction, we may have to pull back depending on what's happening. So we're going to see sort of a back and forth, I think, over the next several months. So I'm cautiously optimistic as our local numbers are down, although I'm a little bit concerned about sort of lack of buy-in that I see sometimes among some of my fellow community members. We'll have to see what happens in the winter and fall when people are less likely to be outdoors. I'm a little concerned that may increase the rate of infection again. And unfortunately, I don't think the vaccine is going to be here as soon as any of us would like it to be, but there certainly are some early promising results with what's out there. So, thank you very much, and that is my talk for today.